to Dr. Chilip, you can start presenting your case.
Yes, sir. A 59-year-old male, Bhagavati Ishwaran from Pollachi, manual laborer by work, came with chief complaints of swelling in the anterior aspect of the neck for the past 2 years. The patient was apparently normal before 2 years. Then he noticed swelling in front of the neck, which is insidious in onset, gradual in progression, not associated with pain and fever. Patient had no history of difficulty in breathing, no history of difficulty in swallowing, no history of hoarseness of voice, no history of syncope and blackouts, no history of constipation, no history of weight gain, poor appetite, no history of cold intolerance, no history of lethargy, and no history of hair loss. Patient had no history of diarrhea, no history of tremor or heat intolerance, no history of insomnia, no history of chest pain or palpitation, no history of weight loss. Patient had no history of bony pain, no history of cough with hemoptysis, no history of jaundice. Past history, patient had no history of similar illness in the past, not a known case of diabetic, hypertensive, asthmatic, TB, CID or seizure disorder. Drug history, no history of any drug intake in the past. Personal history, mixed diet, smoker for past 20 years, stopped 10 years back. He's having 10 cigarettes per day, not an alcoholic or tobacco abuse. Family history, no history of similar illness in the family members. General examination, patient is afebrile, patient conscious, oriented, moderately built and moderately nourished, no pallor, no icterus, no sinuses, no clubbing, lymphadenopathy and fetal edema. No toxic eye signs present, no tongue and hand tremors present, carotids felt, no elevation of JVP. Vitals, pulse rate 80 per minute, regular in rhythm, normal in volume. BP 130/90 mmHg, measured in sitting position, right upper arm. Respiratory rate 18 per minute, SpO2 98% in room air. Local examination. Patient in sitting position, neck extended and inspected from front. A swelling of size 5 x 3 cm seen in the anterior aspect of neck. The surface is smooth, extending from right anterior border of sternocleidomastoid to left anterior border of sternocleidomastoid and 2 cm above the sternal notch. Swelling becomes less prominent on extending neck, that is deep to deep fascia. Skin over the swelling is normal, moves up with deglutition, lower border is seen, does not move with protrusion of tongue. Palpation after getting consent, swelling is not warm, not tender. Swelling of size 5 x 3 cm of spherical shape, present in anterior aspect of neck, extending from right anterior border to left anterior border of sternocleidomastoid. Its upper border is 4 cm from the mentum, lower border is 3 cm from the sternal notch. Nodular in surface, firm in consistency. No palpable thrill. Percussion resonant of manubrium. Auscultation, no bruit on superior pedicle. Examination of spine and cranium, normal. Systemic examination, cardiovascular system, precordium normal, no dilated veins. Palpation, apical impulse in fifth intercostal space, just medial to mid-clavicular line. SNS2 here and no murmur. Respiratory system, chest normal inspection. No use of accessory muscles for respiration, normal vesicular breath sounds, no added sounds. Abdomen soft. CNS, patient conscious, oriented, cranial nerves are intact, power of all limbs 5/5, tone is normal, sensory system normal. Airway examination, no facial distinct features, bilateral nasal passages patent, interior gap 3.5 cm, sternomental distance not measured, thyromental distance not measured, temporomandibular joint, no ankylosis. Tongue normal in size, Mallampati grade 3, no bucktooth or loose tooth, neck circumference not measured, neck movements flexion restricted, spine normal alignment. Investigations include hemoglobin, total count, differential count, platelets and ESR, bleeding time, clotting time, random blood sugar, renal function test, chest X-ray and ECG. Specific tests for this patient include X-ray AP lateral view, indirect laryngoscopy for vocal cord mobility, ultrasound neck, FNAC, thyroid profile and CT neck. Diagnosis: 59-year-old male with swelling in anterior aspect of neck without airway compromise, without complications, normal thyroid function, without comorbidity, scheduled for subtotal thyroidectomy.
Okay. Good. So we'll go one by one. Can you see my screen?
Yes, sir.
Yeah. So we'll go one by one from history and so on.
Okay.
And this is the Telegram group. And what I've done is like I'll record all the videos and I'll share because the size will be too large to this thing. So I thought we'll share in the Telegram group as well as in the YouTube channel so that everyone can view a little later. So coming to this case, what's the importance of asking patient's age, gender, or place of residence and socioeconomic status?
Regarding age, certain disorders of certain thyroid diseases are particular in certain age, sir.
Okay.
For example, colloid goiter is more prevalent in adult and adolescents.
Okay.
Malignancy is more common in
Hello.
general place of residence.
Yeah.
General place of residence. Thyroid female gender. Place of residence. Patient living in hilly areas are more prone to iodine deficiency, and so they develop goiter more frequently.
Okay. So thing is like the hypo or hyperthyroidism is more common in the age group of 20 to 30 years of age, and more in females rather than in the male. And place of residence is like anyone like what you told from hilly areas or the coastal areas where the low iodine consumption is less, and it is more common. Malignancy is more common in males compared to the other type. Iodine deficiency and the socioeconomic status. Iodine deficiency is more common in lower socioeconomic status.
Hello.
Patient. Yeah.
Sir?
Yeah. Can you hear?
Yes, sir. Yes, sir.
Yeah. Yeah. Iodine deficiency is more common in the poor socioeconomic status patient. That's why we ask for age, gender, and place. Okay. What are the presenting symptoms usually for the patients?
Presenting
what are
complaints.
the presenting? Yeah.
Presenting complaint would be swelling in the anterior aspect of neck, sir.
Yeah.
Then patient may have symptoms of hyperthyroid and hypothyroid symptoms, sir.
Yeah. Yeah.
Hyperthyroid symptoms include patient general look will be anxious, more excited, and patient will have tachycardia.
Okay.
Patient will have resting tremors.
Okay. So to divide this, we can say like every system wise. General, then anything related to central nervous system, anything related to cardiovascular, or anything related to gastrointestinal or genitourinary. So if you divide by this, you will not miss anything. So usually any of the system problems the patient will present to. So maybe the weight loss in general, it may be the weight loss what you're doing, no? So, weight loss, heat intolerance, and so on, muscle wasting. Sometimes muscle weakness might be the one of the this thing, or irritability if it comes to central nervous system, hyperkinesia, tremor, or cardiovascular. It may be because of palpitation, angina, breathlessness. Sometimes anything related to cardiac failure and so on. Gastrointestinal may be increased appetite if it is a hypothyroidism, or constipation or diarrhea, depending upon the hypo or hyperthyroidism. So if you can divide into general, cardiovascular, system-wise, then it will be easier for you to tell everything. Okay. So why does hyperthyroid patient develop heat intolerance?
Hypothyroid patient will usually have increased metabolism, sir.
Yeah.
So increased metabolism. So metabolic end products will be released and cause peripheral vasodilation, sir.
Yeah. Okay. So usually the basal metabolic rate as such will be increased.
Yes,
That is why the patient will have heat intolerance.
yes, sir.
Yeah. So when can the swelling increase in size rapidly?
And the conditions of hemorrhage, inflammation, and malignancy, sir.
Yeah, good. When the patient can complain of pain in the swelling?
Hemorrhage, inflammation, sir.
Yeah, good. Inflammation. Anything like thyroiditis or hemorrhage
Thyroiditis
can.
or
Yeah, good. What are the symptoms of hyperthyroidism?
general symptoms will be patient will be having weight loss despite of increased appetite, sir.
Yeah.
Patient will be having disturbed sleep, sir. The insomnia will be there.
Yeah.
The patient will be always excited, anxious.
Yeah.
Fine resting tremor will be present, sir.
Okay. Okay.
Regarding respiratory system, due to increased basal metabolic rate, to eliminate excessive carbon dioxide, patient will rapid and deep respiratory rate, sir.
Okay, good. So same thing here. If you can divide between the systems, what you told, you will not miss anything. So basically, you can start with cardiovascular system, then go with central nervous system, and so on. Okay. Then what are the clinical features caused by the pressure effects by the thyroid swelling? You told no history, so everything, but each history has some clinical feature behind it.
Yes, pressure effects. Thyroid swelling will exert pressure over trachea, esophagus, recurrent laryngeal nerve, or sympathetic chain. Pressure effect over trachea may cause dyspnea and stridor, sir.
Okay.
Pressure effect over esophagus may cause dysphagia.
Yeah.
Pressure over recurrent laryngeal nerve may cause hoarseness of voice.
Yeah.
Sympathetic trunk may cause Horner syndrome, sir.
Yeah.
Or malignant thyroid swelling may engulf carotid.
Okay. Yeah, good.
What is Horner syndrome?
Horner syndrome causes ipsilateral enophthalmos, meiosis, and decreased sweating in one side of face. Sir.
Okay. Okay.
So, what are the different types of cancers? Thyroid cancer.
Thyroid cancers is divided into differentiated and undifferentiated, sir.
Yeah, good.
Undifferentiated will is anaplastic carcinoma, sir.
Okay.
Differentiated will be follicular and papillary carcinoma, sir.
Okay. So
papillary and medullary carcinoma.
Yeah, medullary carcinoma. Good.
Vijay,
yeah.
Vijay,
Yes, sir. Yes, sir. Yes, sir.
So, we were talking about pressure effects, no?
Yes, sir.
So suppose if the thyroid is having a retrosternal extension, what are the pressure effects you will expect?
Retrosternal extension may cause superior vena cava obstruction, sir.
Okay.
Superior vena cava obstruction may cause venous engorgement over face, causing a dilatation and edema over face, sir. Flushing,
okay.
Dilatation, pains, and edema face, sir.
Okay. What else it can produce? Is there any variation in difficulty in breathing?
Patient will have fixed obstruction.
So at what time patient will be prone for difficulty in breathing?
During patient lies supine, sir.
Yeah.
And during sleep.
During sleep.
Yeah. Okay. 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 Continue.
Yeah. What is the name of autoimmune thyroiditis?
Hashimoto's thyroiditis.
Yeah. Good.
Due to
Yeah. Tell me.
Due to antibodies against anti-microsomal and anti-thyroglobulin antibodies.
Correct. Okay, good. So, what is euthyroid 6 syndrome?
In euthyroid 6 syndrome, there will be low TSH, T3, and T4 due to non-thyroid illness, sir.
Okay. Yeah. Correct.
Due to cytokine and inflammatory mediators, actions on hypothalamus, pituitary, and thyroid glands, sir. Once
good.
the rate of reduction of T3, T4, and TSH will be related to severity of illness.
Yeah.
Once the illness settles, patient will have normal thyroid profiles.
Good. So usually it happens in any severe illness, pneumonia, starvation, sepsis, trauma, any cardiopulmonary bypass, myocardial infarction, malignancies, and so on. So there are a lot of conditions which can cause euthyroid syndrome. Okay. So what's Wolff-Chaik's effect?
Wolff-Chaikoff effect is large dose of inorganic iodoids can cause a reduction in affect every stage of thyroid synthesis and release.
Yeah, good. A reduction in thyroid hormone level, so injection of a large amount of
inorganic iodides.
Yeah, good. There are a lot of tests which has been done to diagnose thyroid. Which will be the single test to help in diagnosing thyroid?
Thyroid profiles.
Yeah, thyroid profile.
TSH.
Single test. Yeah, good. TSH.
TSH.
So yeah, TSH will be the single test which can help in diagnosing thyroid illness. Okay.
Yes.
What are the causes of hyperthyroidism?
Cause will be primary and secondary, sir.
Yeah.
Primary is due to Graves' disease, sir.
Okay.
Secondary may be due to inherent thyroid disease, toxic multinodular goiter or toxic adenoma.
Okay.
Or related to thyroid storage and release, which will be due to thyroiditis.
Okay.
Or excessive TSH stimulation due to trophoblastic tumor.
Yeah.
Or Graves' disease.
Yeah.
Or due to excessive TSH production due to pituitary thyrotropin tumor, pituitary thyrotropin secreting tumor, sir.
Yeah, good.
Or extrathyroidal hormone synthesis, thyroid synthesis like struma ovary and struma ovary, sir.
Yeah, good.
And exogenous more thyroid supplementation or iodide intakes.
Yeah, good. So you told primary and secondary hyperthyroidism.
Yes,
so tell something about primary and secondary hyperthyroidism.
Primary hyperthyroidism, the symptoms will appears in patient. Patient may or may not have swelling, sir. In secondary hyperthyroidism, patient will have long-standing swelling, and the patient develop hypothyroid symptoms, sir. In primary hyperthyroidism, there will be more of CNS manifestations, sir.
Good.
In secondary hyperthyroidism, there will be more of cardiovascular manifestations.
Cardiovascular manifestation. Okay. What are the drugs that can produce goiters? Because we'll have take the treatment history also, no?
Yes, sir.
Yeah.
Cough syrups containing potassium iodide.
Good.
Amiodarone, sir.
Yeah, good.
Antitubercular drugs such as paramonosalicilates.
Yeah.
Anti-maniac drugs, lithium carbonate.
So this can cause goiter. Yeah. What are the menstrual disturbances in hypo or hyperthyroidism patients?
And both hypo and hypothyroidism, and both men and women it produce impotence, sir.
Okay.
In hyperthyroidism, menstrual symptoms includes hyperthyroidism, oligomenorrhea, sir.
Okay.
Amenorrhea and oligomenorrhea. Hyperthyroid, polymenorrhea, and menorrhagia will be there.
Okay. Okay. So, what are the skin changes you can see in the hyperthyroidism?
Skin changes in hyperthyroidism, the patient will have pretable myxedema, sir.
Okay. Okay.
Mucopolysaccharide deposits in dermis, which causes reddish elevated lesions, which is non-pitting.
Okay. Okay. So that is in hypothyroidism.
Hyperthyroidism.
Hypo. Yeah.
Mainly in pretibial regions.
Yeah. Yeah. Okay. Hyperthyroidism.
Wow. Patient will have warm and moist skin, sir.
Yeah. Good. So and hairs may be brittle.
Hair brittle, sir.
Alopecia. Yeah, alopecia. And sometimes there will be increased pigmentation will be there. Okay. What type of tremors are present in hyperthyroidism, and how will you test to
Hello,
detect
sir.
it? Yeah. What?
Yes, sir.
Yeah.
Yes, sir.
Can you see that question? What type of tremors are present in hyperthyroidism? How you will detect it? Or
Hello, sir.
yeah.
Yes, sir.
Hmm.
Patient will have fine resting tremors, sir.
Good. Yeah.
A piece of paper is placed over patient's hand. Patient will outstretch the hand, sir.
Yeah. Good.
A piece of paper will be placed over patient's hand. We can visualize the fine tremors.
Yeah. How will you test the tremors in the tongue?
Patient is asked to protrude the tongue, sir.
Okay. Protrude the tongue or anything else? Tongue. Ask the patient to open his or mouth, keeping the tongue in the floor of the oral cavity. You should not ask to protrude. The muscles of the tongue should be, you should not contract.
Relaxed.
Yeah.
Okay, sir.
Okay. And what are the neurological manifestation of hyperthyroidism?
Neurological manifestation will be excitability.
Yeah, good.
Excitability, sir. Mainly excitability.
Yeah.
Patient will have nervousness, anxious.
Yeah.
Then decreased sleep, insomnia.
Okay. The reflexes will be.
Reflexes will be brisk reflexes. Yes, sir. Followed by fast relaxations.
Yeah. And patients will have proximal myopathy too.
Proximal myopathy, sir.
Yeah. And what are the pulmonary manifestation of hyperthyroidism?
There will be increased due to basal increased BMR. There will be more utilization of oxygen consumption, sir.
Yeah. Yeah.
So there will be more of byproduct production, leading to rapid and deep breathing, sir.
Okay. So there will be a reduction in the vital capacity.
Yes, sir.
And the lung compliance also will get reduced. And moreover, yes, the airway reactivity also will increase. Increase. And the airway resistance also will increase. There will be restricted flow pattern in the lung, isn't it?
Yes, sir. Yes, sir.
Yeah. And what are the ocular manifestation of hyperthyroidism?
Ocular manifestations include various signs are there, sir, for hyperthyroid patient. Dalrymple sign is patient will have lid retraction, sir.
Okay.
There is visibility of upper white of sclera will be visible, sir.
Okay.
Dalrymple sign. Von Graffi sign is lid lax sign, sir. When patient is asked to follow the object downwards, the lid will not follow the eyeball, sir. There will be lid lax, sir.
Okay.
Geoffroy sign is absence of wrinkling of forehead when the patient is looks upwards, sir.
Okay.
Mobius sign is absence of convergence of eyeballs due to ophthalmoplegia.
Yeah, good.
Stellwalk sign is patient will have star look with infrequent blinking.
Yeah. So, how do you grade exophthalmos in patients? Mild, moderate, and severe. How do you grade?
No idea.
Yeah. So there are 3 grades: mild, moderate, and severe. In mild cases, it consists of widening of the palpebral fissure alone due to the retraction of the upper eyelid without any bulging of the eyes. Here, Stellwag sign and von Graffi's sign are positive. In moderate, it is due to actual bulging of the eyeballs from the increased decomposition of the retrobulbar fat. And in moderate exophthalmos, the Dalton-Pease and Geoffroy signs will be positive.
Yes, sir.
And in severe cases, it's due to the intraorbital edema and congestion. Here, this Mobi sign will be positive. So it is a mild, moderate, and severe grade of exophthalmos. Okay. So, and you told about the common signs. What is Berry sign?
Berry sign is absence of carotid artery pulsation due to malignant engulfment of carotid sheaths. Sir.
Yeah, good. What is Pemberton?
Pemberton sign is to diagnose the retrosternal extension, sir. The patient is asked to raise her hands above the head, touching her ears. Within few seconds, patient will have flushing of face and dilated veins and edema. Patient may go for shock due to superior cava obstruction by retrosternal extension of coitus.
Yeah, good. Any other midline swelling in the neck? Apart from
Thyroid swelling, thyroid cyst.
Yeah.
Subaortic bursitis.
Okay.
Pretracheal, subtracheal lymph nodes, prelaryngeal lymph nodes.
Okay. Dermoid cyst, submental lymph nodes, and so on. Okay.
Yes.
So, what are the swellings which moves on deglutition?
Thyroid swelling, thyroglosal cyst, and subtracheal lymph nodes.
Okay. So thyroglossal. Okay. How do you differentiate between thyroglossal cyst and thyroid swelling?
Thyroglosal cyst swelling will move with protrusion of tongue, sir. But thyroid swelling will not move with protrusion of tongue, sir.
Yeah. Any other thing will move on protrusion of tongue apart from thyroglossal cyst? Lingual thyroid.
Yes, sir.
Lingual thyroid will move on protrusion of tongue. Okay. In which condition thyroid gland does not move on deglutition?
Thyroid it is or malignant.
Yeah, good. Yeah.
Thyroid affixed to adherent structures.
Yeah, good. Yeah, just in structure. Okay. And you told the methods of examination. One method
Yes,
of examination. Yeah, just to mention about other ways of examination of thyroid.
During inspection for obese patients, obese and short neck patients, Bigelow method is used, sir.
Okay.
In that method, patient is asked to clasp hands and keep hands behind the occiput so that thyroid swelling becomes prominent, sir, during inspection.
Okay.
During palpation, to palpate each lobe each lobe of thyroid distinctly, we use a Lahey's method, sir.
Okay.
In Lahey's method, to palpate left side, right side of the thyroid gland is pushed towards left, and it is palpated with left hand, sir.
Okay.
Palpated with right hand, sir.
Okay.
Then
the examiner stands in front of the patient. Okay, to palpate the left lobe, thyroid gland is pushed to the left from the right side to make the lobe more prominent. Okay, and should be palpated with the other hand.
Other hand.
Yeah. So another Kreil's method.
Kreil's method, sir. Palpation of thyroid with using thumb, sir.
Yeah. Okay. I think sir has asked what coaches does, no?
No, sir.
Okay.
Why, Jackman?
Yes, sir.
Okay. So you're told that thyroid gland moves with deglutition. Why it is moving with deglutition?
So thyroid gland is attached to pretracheal fascia, sir.
Okay.
So it moves with deglutition.
Yeah.
Okay.
Okay. What's Koch's test?
Koch's test is used to identify whether thyroid swelling is compressing trachea, sir.
Okay.
When gentle pressure is applied to one of the lateral side of swelling, it causes compression. The patient will have symptoms of dysphagia, sir. Dyspnea or stridor, sir.
Okay.
It shows positive coaches showing thyroid compression over trachea.
Okay. So, what's the importance of sleeping pulse rate, and how will you do it? Sleeping pulse rate.
Usually, while awake patient will always be anxious and palpation will be there, sir. So for a thyroid patient, it will be reliable to measure sleeping pulse rate, sir. Sleeping pulse rate should be measured after antithyroid medication without having without beta blocker therapy, sir.
Okay.
Sleeping pulse rate measured, and it is graded as mild, moderate, and severe, sir.
Okay.
Less than 90 is graded as mild, and 90 to 110 is graded moderate, and more than 110 sleeping pulse rate is severe, sir.
Yeah, good.
What is desirable?
Less than 90 per minute, sir. Mild. Less than 90 per minute. Sleeping pulse rate of less than 90 per minute, sir.
Okay.
So while doing examining the pulse, sleeping pulse rate, what other things you can examine in the pulse?
Regular, whether it is regular or irregular, sir.
Yeah.
Since AF is more common in hyperthyroidism, arrhythmia.
Yeah, good.
More
Yeah.
common arrhythmia in hyperthyroidism.
So mostly the rhythm is tested. Okay. Will there be any change in the blood pressure in the hyperthyroid patient?
Yes, there will be increase in systolic and reduction in diastolic pressure, sir. So that there will be wide pulse pressures.
Pulse pressure. Yeah, good. What type of cardiac failure you will expect in thyroid patient?
Hyperthyroid patient, there will be high output cardiac failure, sir. High output left ventricular
They will
failure.
go in for high output cardiac failure. What are the neuromuscular effects of hyperthyroidism in muscles?
Neuromuscular effects will be patient will have proximal myopathy, sir. Muscle weakness will be there.
Yeah.
Due to increased protein catabolism, sir. Prolonged protein catabolism.
Okay. So we'll see something about anatomy apart from this history. So can you tell me some embryological embryology of thyroid?
Thyroid derived from endodermal thyroid diverticulum, sir.
Okay.
From primitive pharynx.
Okay. Something about anatomy of thyroid?
Yes, sir. Anatomical extent for vertebral includes C5, C6, C7, and T1, sir.
Okay.
Regarding tracheal rings from thyroid cartilage to 4th, 5th tracheal cartilages, sir.
Okay. So thyroid gland is developed from two main structures. It is primitive pharynx and the neural crest. So this rudimentary lateral thyroid develops from the neural crest. Mainly it is from the primitive pharynx. Okay, from the pharyngeal bud. So the thyroid extends in the middle 4th to 5th tracheal rings. What is the arterial, venous and the nerve supply of thyroid?
Arterial supply is superior and inferior thyroid artery, sir. Superior thyroid artery is branch of external carotid artery, sir.
Okay.
Inferior thyroid is thyrocervical trunk from subclavian artery, sir.
Yeah, good.
Venous supply is superior, inferior, and superior, middle, and inferior thyroid veins, sir.
Okay.
Superior and middle thyroid vein drains in interjugular veins, sir.
Okay.
Then inferior thyroid vein drains in brachiocephalic vein.
Yeah, left brachiocephalic vein. Okay.
Yes, sir.
So nerve supply. So this is cervical ganglion of the sympathetic trunk. What is thyroidema?
Thyroidema artery, some the direct artery from arch of aorta, sir. Some will have thyroidema artery.
Yeah, 3% of patients will have a direct supply from the arch of aorta. Okay, what is the role of thyroid hormone in humans?
Yes, hello.
Yeah, what is the role of thyroid hormone?
Thyroid hormone, it involves in growth development all cells in the body, sir.
Yeah.
So most important for neural development and skeletal maturation, sir. Yeah,
good. So it increases because of this, it increases the basal metabolic rate of this thing, and it also regulates the protein, fat, and carbohydrate metabolism. What are the hormones secreted by thyroid gland? What are the other hormones?
Thyroxine, triiodothyronine, and
T3 and T4.
T4.
Yeah. Briefly tell about how the thyroid hormone synthesis of thyroid hormone.
Yes, sir. First step in thyroid hormones, usually 5 steps are there, sir. Iodine trapping, oxidation, organification, coupling, storage, and release, sir.
Okay.
Iodine trapping involves sodium and iodide, counter transport, symport, sir. Sodium iodide symport involved in iodine trapping, sir.
Okay.
Then it is coupled with tyrosine residues of thyroglobulin, sir.
Okay.
Then iodide is oxidated to iodine and is organified into thyroglobulin molecule as mono and diiodothyronine, sir.
Tyrosine. Okay.
This steps involves first iodine trapping involves thyroid stimulating hormone hormone, sir.
Okay.
Oxidation involves thyroid peroxidase and hydrogen peroxidase.
Okay.
Then coupling occurs, sir. Mono and diiodothyronine couples to form triiodothyronine, and two diiodothyronine couples to form thyroxine, sir.
Okay.
This is also mediated by thyroid peroxidase enzyme, sir.
Okay. Yeah.
So this is stored in follicular cells of thyroid, sir.
Yeah.
Then it is released by uptake into epithelial cells of thyroid by process called pinocytosis, sir.
Okay.
So it is cleaved by lysosomal enzymes, digestive enzymes, and released as T3 and T4 into the blood, sir.
Okay. So what are the hormones involved in synthesis and release of T3 and T4 from thyroid hormone?
From hypothalamus, thyrotropin releasing hormones released, sir.
Yeah.
From anterior pituitary, thyroid stimulating hormones released, sir.
Okay.
These T3 and T4 negatively cause negative feedback release of TSH, sir.
Okay. Good. So what is the daily amount of T4 secretion?
100 micrograms per day, sir.
100 micrograms per day. Okay. What is the half-life of T4 and T3?
Half-life for T4 is 7 days, sir.
Okay.
Half-life for T3 is usually 36 hours, sir.
Yeah, 24 to 36 hours.
Yes, sir.
Because it is very important when in the post-operative period whether to continue the antithyroid and beta blockers. Okay. What are the differences between T4 and T3?
T3 is has shorter half-life and T4 is a longer half-life, sir.
Okay.
T3 is metabolically active, sir. T4 is peripherally converted into T3, sir.
Yeah.
90% of synthesized thyroid will be T4 only, sir. Only a small portion will be T3, sir. T3 is 3 to 5 times more potent than T4.
Yeah, good. That is why for treatment we used to give T3. Okay.
T3.
Can you name some of the associated endocrine disorders?
Okay. Men's syndromes will be associated with other disorders, sir.
Yeah.
Men 1 syndrome will be with pituitary adenoma, parathyroid hyperplasia.
Okay.
And pancreatic tumors like insulinoma, sir.
Okay.
Men 2A will be medullary carcinoma, thyroid, pheochromocytoma.
Okay.
And
parathyroid. Yeah, parathyroid hyperplasia and edema. 2B?
2B will be medullary carcinoma and pheochromocytoma and
multiple mucosal neuromas and intestinal ganglioneuromas. Okay. So we'll come to some of the investigations and treatment. You told you have mentioned some of the investigations, and what are the different thyroid function tests which are done to see whether it is hypo or hyperthyroidism?
Thyroid TSH, free T3, free T4.
Okay.
Total T3, total T4, sir.
Yeah. So can you name some normal levels? You know.
TSH
T4.
is the point.
Yeah, TSH.
TSH is 0.5 to 5 milli international units per ml, sir.
Okay.
T4. Total free T4 will be 1.5 to 3 nanograms per deciliter, sir.
Yeah.
Free T3 will be 3 to 5 picogram per deciliter.
Okay. Okay. Any other investigations done for hyperthyroid patients? Any radioactive uptake test?
Radioactive to to see the function, whether it is functional thyroid or not.
Yeah.
Radioactive iodine test, sir.
Okay.
Using technetium or iodine, sir.
Yeah. Okay. So, why do you consider patients with a goiter having a difficult airway? Why do you say they have a difficult airway?
Patient having large swelling when they lie in supine and after giving induce the patient, they lose their spontaneous respiration, sir.
Okay.
Then their muscle tone will be lost, so that huge swelling will be pulled down to our trachea. It may cause tracheal compression, sir.
Okay.
Large swelling is itself cause a difficult laryngoscopy.
Yeah, good. Yeah.
May cause deviation of trachea, so that view during laryngoscopy may be difficult, sir.
Yeah. Okay.
Or LMA will be difficult. It may have intratracheal extension also. So during intubation, it may cause bleeding or dislodgement of tumor into distal respiratory tract.
Yeah, good. So, as such, there are a lot of external and internal problems will cause difficulty, will have a difficult airway. Okay.
Yes, sir.
Yeah. So, what are the different treatment options for hyperthyroidism?
Antithyroid drugs, which includes antithyroid drugs, which includes thiacyanates and propylthiouracil, sir.
Okay.
Then beta blocker therapy.
Okay.
Then iodine therapy.
Okay.
Then steroids, sir.
Okay. So, how each one will help in managing the patients in hyperthyroidism or?
Thiacyanates will act at iodine trapping and blocks iodine trapping, sir.
Yeah.
So iodine trapping will be reduced. The propylthiouracil will cause will inhibit oxidation organification process, sir.
Okay.
So that iodine will not be bound to thyroglobulin molecules.
Okay.
Inactive iodides will act at various levels of in thyroid synthesis, sir. Taxate iodine trapping organification, and also it blocks the release of thyroid hormone into the bloodstream, sir.
Okay.
Beta blockers usually give symptomatic treatment for hyperthyroid patients, but it has no relation with hormone levels.
Yeah. So it helps in peripheral conversion, inhibit the peripheral conversion of, yeah. So
Yes,
what is the dosage of is carbimazole or propylthiouracil?
Yes, sir. For propylthiouracil, it is usually 200 to 300 mg 6 to 8 hourly, sir.
Okay.
Carbimazole is 20 mg 6 hourly, sir.
Yeah.
Methimazole is 30 to 40.
Yeah. So other options is radioactive, radioiodine ablation and surgery.
Yes,
that is what we are going to talk about. Okay.
Yes.
Okay. So what are the common side effects of antithyroid drugs?
Propylthiouracil is prone to cause agranulocytosis, sir.
Yeah.
And other antithyroids may cause vasculitis, skin rashes.
Yeah. Toxicity and so on. So,
Yes,
what is the common complaint you will elicit in the patient to have to find out the side effect of antithyroid drugs? For example,
patient will have gum bleeding, sir.
Okay,
gum bleeding.
Okay, usually it is the pharyngitis. Pharyngitis will elicit the patient having any pharyngitis to pharyngitis.
Pharyngitis.
Yeah. Why patient should be brought to euthyroid state before surgery? Why not can have it in hypo or hypothyroidism?
Any hypothyroid patient in stress, trauma, or any surgery induced, patient may go for a thyroid storm, sir.
Yeah.
Or hypothyroid patient and prolonged anesthesia may mixed edema coma, sir.
Yeah.
So patient should be brought.
Yeah, they will have a higher oxygen requirement based on metabolic rate is high, and all the requirement will be high, MAC will be high, so everything will be deranged. That's why we need to, and patient will have a hypo or hypertension. Then there will be rhythm disturbances will be there, and so on. So that's why we prefer to have a patient under euthyroid state.
Euthyroid state.
Yeah. How will you prepare a hyperthyroid patient for elective surgery?
Hello, sir.
Yeah. How will you prepare a hyperthyroid patient for elective surgery apart from these things with antithyroid drugs?
Apart from antithyroid drugs, for urgent or semi-urgent surgeries, patient
elective surgery. Elective surgery.
For active surgery, antithyroid drugs continued for at least 4 to 6 weeks to normalize the thyroid. 6 weeks, at least for 6 weeks to normalize the thyroid profile, sir.
Good. And what about glucose iodine?
Glucose iodine causes thyroid constipation, sir. Glucose iodine composition is 5% iodine and 10% potassium iodide.
Yeah.
It is given 3 drops 6th hourly for 10 days, 10 to 14 days, sir.
Okay.
It causes reduction in swelling size, vascularity, and consistency of swelling is also reduced to form, sir.
Okay. So
how do you know that
Yes, sir.
How do you know that the patient has become euthyroid?
Patient general symptoms should be assessed, sir.
Okay. Then
a thyroid profile can be done, sir.
What you will see in thyroid profile? Will there be any change in TSH?
No,
will
sir.
There be any? Huh? So what will be the TSH in hyperthyroid?
Hyperthyroid will be reduced. TSH will be reduced.
So it will begin to normalize.
Yes, sir.
Okay.
Yes, sir.
And T3, T4 levels will also come down.
Yes, sir.
Okay. Apart from your clinical symptoms, improvement in clinical symptoms.
Yes, sir.
Okay. Good.
So how long you will give this iodine?
10 to 14 days, not more than 14 days, sir.
Why?
More than 14 days, this exogenous iodine will be used up by the thyroid, worsening the thyrotoxicosis, sir.
Yeah.
Effect is known as jade-based effect.
Yeah. So otherwise, what is the other name? It is called thyroid escape.
It's a thyroid escape.
Yeah. So anything else, sir, apart from anesthesia? Anything else, sir, wants to ask?
Suppose if this patient is comes for an emergency.
Yes, sir.
So how will you prepare this patient?
For
emergency, elective, we have got a time up to 4 to 6 weeks. We have got an adequate time to prepare this patient.
Yes, sir.
Suppose this case has to be done immediately.
Yes, sir. Patient is started with the propel thyroxine, sir.
Okay.
Propel thyroxine 200 mg through rail tube given, sir. Then after antithyroid drugs, after 1 hour, iodide therapy is given, sir.
Okay.
Then a beta blockers are started, sir. Propanol at dose of 0.5 mg per kg, sir. IV bolus is given, sir.
Okay. Is there any other drug that can be given that will act immediately in a beta blocker? Other than propanol? It's an emergency, no?
Yes, sir. Esmolol.
Yeah. What is the dose?
It's 0.3 mg per kg, sir. 0.3 to 0.5 mg per kg, sir.
Okay. Better check more.
Yeah.
You can take over.
Yeah. Coming to till now we were talking about medicine. Coming to anesthesia. So what are the different types of thyroidectomies patient will be posted for these things for anesthesia? What are the different types of surgeries? Thyroidectomy.
Hemithyroidectomy, sir.
Okay.
Subtotal thyroidectomy.
Okay.
Total thyroidectomy, sir.
Okay. What is the difference between each? So So hemithyroidectomy, the entire isthmus is removed along with the one lobe of thyroid.
One lobe.
Usually it is done in the benign diseases. Okay. Subtotal thyroidectomy is removal of majority of lobes, leaving behind about 5 grams of thyroid. This is usually done in multinodular goiter. Okay. Then something called partial thyroidectomy. It is done in non-toxic multinodular goiter. So it is, I think it is not done now. Other thing is a near total thyroidectomy, where both the lobes are removed except a small amount of thyroid tissue is left in the vicinity of recurrent laryngeal nerve. Okay. Other one is total thyroidectomy, where entire gland is removed. Usually it is done for carcinoma and sometimes for multinodular goiter also. Okay. So in this total thyroidectomy, we'll encounter postoperative hypoparathyroidism or nerve injuries. Okay. So these are the different types of thyroidectomies. So coming to how will you premedicate these patients?
Patient is seen the day before the surgery, sir.
Okay.
Premedication given overnight, benzodiazepine, diazepam 10 mg, the previous day night can be given, sir. Sedative premedication.
Okay.
Then to reduce the anxiety, sir.
Okay. Okay.
Then,
so morning also will give the same benzodiazepine. Morning also before the surgery.
Yes,
and what are the drugs you will continue? Yeah.
The patient is asked to continue antithyroid drugs and beta blockers, sir.
Beta blockers. Yeah, good. Okay.
Then glycopyrrolate usually avoided.
Yeah.
Usually avoided due to risk of increased heart rates.
Okay. So what are the usual monitors we'll use?
What is other problem with glycopyrrolate other than increase in heart rate? Will it interfere with the temperature regulation?
Yes,
anticholinergics. So we are expecting there may be a possibility of thyroid storm intraoperatively, no?
Yes, sir.
So if you give anticholinergics, it will also increase temperature. So that may confuse your diagnosis.
Yes, sir.
So it's better to avoid.
Yes, sir.
Okay.
What are the routine monitors we'll use for thyroid?
So pre-induction monitors will be ECG, SpO2, and non-invasive BP, sir.
Okay.
Other than that, intraoperatively, we should use ETCO2 and temperature monitoring, sir.
Yeah. Okay. Good. So these are the basic monitors. What is the type of induction you will use for this?
For this patient, type of induction would be IV induction of choice, sir.
Okay.
For moderate swelling, inhalation induction could be used, sir, which preserves spontaneous ventilation.
Okay.
For a very large, long-standing thyroid swellings, fibrotic bronchoscopy would be ideal, sir.
Okay. So if you expect difficult intubation, you can go in for awake intubation. Yeah.
Yes,
sorry. Can you see the screen now?
No, sir.
Yeah. Can you? I think someone's phone is ringing. 1 minute. Can you see the screen now?
No, sir.
No. 1 minute. Now you can see?
Yes, sir.
Yeah. What is the induction agent of choice when you say it is an intravenous induction?
For this patient, I prefer propofol, sir, since it reduces sympathetic stimulation, sir.
Yeah, good. And if you have an hyperthyroid patient,
high dose thiopentane can be used since it causes reduction in peripheral conversion of T4 to T3, sir.
Okay. Thiopentone can be used. Okay.
Thiopentone,
So,
sir.
yeah. So, what difficulty will you expect during induction in a patient with a huge goiter?
During induction, patient with a huge goiter will lose spontaneous respiration and muscle tone will be lost, sir.
Yeah, good.
So, due to loss of muscle tone, that large swelling will fall on trachea, compressing the lumen of trachea, sir.
Okay, okay.
Also, spontaneous respiration is lost, creating negative intrathoracic pressure, sir.
Okay.
So, there will be collapse of airways.
Okay, what you'll do?
We may do lateral intubation, sir. Patient lateral position, or ask the assistant to lift the thyroid swelling with forceps during induction, sir.
Okay. So, any name for this thing, lifting the tumor up?
Reverse swelling.
Yeah, that is called a reverse swelling. Yeah.
Reverse swelling.
Yeah. What are the preparations you've done before induction in the operation theater?
OT should be made ready, sir. All the drugs and should be loaded and labeled. Difficult intubation card should be made ready, sir.
Yeah. So in the difficult intubation, what are the what are the things you will keep ready?
Different size CT tubes, including smaller one size, sir. Different size of laryngoscopies and blades, sir.
Okay.
Supraclavic airway devices. Intubating stillet and bougie.
Okay.
Then FOBs and trichothoracic set and tracheostomy sets.
Okay. And what type of endotracheal tube will prefer to use?
Flexometallic usually preferred, sir, due to non-kinking.
Okay. Any other tube?
Ray tube can be used.
Okay. Yeah.
Which ray? Which type of ray tube?
Recording in progress.
South pole.
South pole or north pole?
North pole.
Okay, north pole.
Okay. So you just study about which is which is South Pole and which is North Pole. Okay.
Yes.
Okay. What is the role of LMA in thyroid surgeries? Hello, Philip, are you there?
Sir?
Yeah.
Yes, sir.
Yeah. What is the role of LMA in thyroid? Yeah.
During extubation,
yeah, LMA is used for spontaneous respiration during thyroid surgeries. But most of the anesthetists, experienced anesthetists prefer to have a ET tube, endotracheal tube rather than LMAs. Okay. So what is the muscle relaxant you will use for intubation? Hello?
Connection.
yes.
This connection is lost.
Sir?
Yeah. What is the muscle relaxation? Muscle relaxant you will use for intubation and maintenance preference? For hyperthyroid or any thyroid.
Can be used,
which one?
Vicronium or Atraconium can be used, sir.
Yeah, Vicronium, and preferably it is Vicronium. Okay.
Vicronium, sir.
Yeah.
Vancomycin usually avoided due to its vagolytic action, sir.
Yeah, correct. So what precautions you will take during intubation regarding the suppression of intubation response? Or to prevent the intubation response, what are the things you will do?
Maintain deeper plane of...
maintain the deeper plane of anesthesia.
Yes, beta blockers can be given, sir.
Yeah, beta blockers can be given. What beta blocker?
Esmol also.
Yeah, how much dose is used to prevent?
0.3 to 0.5 mg per kg, sir.
Yeah, usually it is 1 milligram per kg can be used to prevent the response, intubation response. Okay, and you have to keep the laryngoscopy duration very shorter.
Shorter.
Yeah. what other precautions have to be taken before positioning the patient?
Usually, thyroid positioning of patient will be hyperextension of neck, sir.
Yeah,
So
good.
during hyperextension, there will be 2.5 centimeter increase in this tube
Yeah,
in distance, sir. So there is chance of auto extubation, sir.
yeah,
So after positioning the patient, the position of
We have to-
tube should be checked, sir.
yeah, confirmed. Okay.
And also during hyperextension, the strain on the neck will be there, sir. So adequate padding of the
Yeah,
neck to avoid
padding
neck
should be-
strain should be done, sir.
and the head and the eye should be
Eye
protected,
should be padded.
and
Yes, sir.
yeah, lubricants should be used.
Lubricants used.
Yeah, proper lubricants. Lubrication has to be done. Okay.
Yes, sir.
So how the patient should be maintained during the surgery?
Maintenance is usually with oxygen, nitrous oxide, and iso or sevoflurane, sir.
Okay.
With opiates, fentanyl, and vicrodium, sir.
Okay.
Maintain
Okay.
deeper plane to avoid any sympathetic stimulation.
Okay. Good. So you should maintain a deeper plane of anesthesia. Okay. Why do you paralyze and control ventilation? Why not will leave the patient in spontaneous ventilation?
During spontaneous ventilation, patient will have varied deeper and lighter planes of anesthesia, sir.
Yeah,
So
good.
patient may buck at times, causing disturbance for surgery, sir.
Okay.
Then during spontaneous respiration, there is increase in PaCO2 production.
Okay.
So it is ideal to paralyze and control the ventilation.
Yeah. What is steel induction?
Steel induction is for to reduce the sympathetic stimulation for hypothyroid patients, sir.
Yeah.
Patient is usually brought to OT regularly and started on IV fluids and sent to ward, sir, for
Yeah.
few days. And then on the day of surgery, patient is shifted to OT so that the patient will not be anxious.
Yeah, just to get used to the OT setup, they brought 2 or 3 times into the OT and they'll be sent back to the ward. And on fine day, they will be induced. Actually, sometimes they will use B complex infusion, yellow color infusion, so that when they use thiopentone also is yellow, so they'll not be anxious while induction.
Yes.
Okay. So what are the perioperative complications in a hyperthyroid patients?
Periodic complications for large thyroid may cause hemorrhage, sir.
Okay.
Hemorrhage patient, hyperthyroid patient during surgery and thyroid handling may going for thyroid storm, sir.
Okay.
Then accidental extubation of tube. Extubation of tube.
Yeah.
Tube kinking.
During the surgery,
During manipulation.
extubation, or during the surgery, there may be kink of the tube, any
Kinking
bleeding, or any dysarrhythmias. Which is the commonest arrhythmia which will happen in thyroid patients?
Atrial fibrillation, sir.
Atrial fibrillation. Okay. So the patient can have embolism, or they can have thyroid storm.
Yes, sir.
Okay. Why patient will have a delayed recovery from muscle relaxants?
Usually hyperthyroid patients will behave as myasthenic gravis patients, sir.
Yeah.
So the patients will have delayed muscle relaxants. So intraoperative neuromuscular monitoring should be used for hyperthyroid patients.
Yeah.
To calculate the dose of relaxants.
Yeah, good. What is the thyroid storm?
It is life-threatening condition, life-threatening condition of hyperthyroid patients who developed in hyperthyroid patients during surgery or any
Sudden
surgery,
surge
infection,
of
any
thyroid
stress.
hormones. Yeah. When do you expect the thyroid storm to happen?
Usually during surgery up to 3 days post-operatively, sir.
Yeah. Okay. Usually it will present 6 to 18 hours post-operatively. Okay. So what are the clinical features of thyroid storm?
Tachycardia and hyperpyrexia, sir.
Yeah.
Metabolic acidosis and dysarthmia, sir.
Yeah, actually it's what, increase in temperature. That's why sir
Increase in
was
temperature.
telling about thyroid. Temperature probe. Then there will be increase in EtCO2. Patient will have acidosis and tachycardia, arrhythmias. Then usually it is the tachycardia, arrhythmias, increase in temperature, and increased carbon dioxide production. Acidosis will be there. So how will you recognize thyroid crisis under anesthesia? Or
There will be early exhaustion of soda lime.
Yeah, good.
Hyperpyrexia.
Yeah, good.
So what is hyperpyrexia? When will you call hyperpyrexia? Temperature more than 106 degree Fahrenheit. Okay.
Yes.
Okay, continue.
Yeah. So, or the patient will have, there is an increase in the requirement of muscle relaxant.
Oxygen.
Yeah.
Relaxants,
So,
yes,
how
sir.
do you what are the differential diagnosis of thyroid crisis?
Malignant hyperthermia, pheochromocytoma.
Yeah. So, how do you differentiate
Usually in
malignant
hyperthermia, it will be muscle rigidity and elevation of creatinine kinase enzymes, sir.
Yeah. So,
in pheochromocytoma, it will be more of cardiovascular manifestations like tachycardia and hypertension.
Yeah, good. So in malignant hyperthermia, it is temperature increases very fast and it is uncontrollable. Okay.
Yes, sir.
So how do you manage thyroid crisis?
Thyroid crisis should be managed with rapid cool IV fluids should be infused.
Okay, what
Cooling
IV fluid will you use?
Cold IV fluids, cold crystallites.
What crystallite? Dextrose.
Yes, sir.
Okay. Yeah.
Yes, sir.
Okay, glucose containing.
Glucose containing. Then cold blankets or ice packs should be placed over the patient, sir.
Okay.
So patient should be ventilated with 100% O2.
Okay.
Then antithyroid drugs and beta blockers should be started, sir.
Okay. Before doing this, first when you diagnose a thyroid crisis, you will change to 100% of oxygen. Then you will ask the surgeon to stop manipulating the thyroid.
Yes.
Okay. Then that is the second step. First step is 100% of oxygen. Second step is you have to ask the surgeon to stop manipulating the thyroid and all other drugs. Okay.
Yes,
so what are the drugs you will use?
Propyl thyroid is used, sir.
Okay.
300 mg through rails tube.
Yeah.
Then beta blockers, sir.
Okay. What beta blocker you will use?
Propanol 0.5 mg per kg IV bolus, sir.
Okay. Or esmolol. Yes, as I was telling, it is easier to control. Okay.
Yes,
so you have to decrease the heart rate. Okay.
Yes,
then any steroid?
Steroid dexamethasone 6 mg given, sir.
Okay.
Every 6th hour it may be repeated.
Okay.
And then for dysarthmias, magnesium can be given.
Okay. If there is a hypotension?
Hypotension, my patient should be started on vasopressors.
Okay. So phenylephrine will be the choice. What is the mortality rate when a patient develops a thyroid crisis?
20%.
Yeah, it is mortality rate is very high and it goes up to 20%. Okay.
Yes.
During the surgery for hyperthyroidism, when the thyroid crisis usually occurs, that's what we. Any laboratory test can differentiate thyroid storm from hyperthyroidism?
No, sir. Laboratories cannot differentiate thyroid storm from hypothyroidism.
Yeah, it is mostly of clinical
diagnosis.
Yeah. So, what is thyrotoxicosis factitia?
So, no idea.
So, it is a condition caused by injection of exogenous thyroid hormone.
Yes, sir.
Okay, when too much of thyroid hormone is given and thyrotoxicosis occurs That is called thyrotoxicosis affectation. Okay. What if during surgery there is a sudden patient develops sudden hypoxia, tachycardia, hypotension, and loss of EtCO2? What will be your diagnosis, or what you will think during surgery?
Disconnection, sir.
Disconnection. Okay. Tachycardia, hypotension, loss of EtCO2, and patient having millwheel murmur.
Sir?
Where millwheel murmur? Where do you get the millwheel murmur? Which position usually will have the OT table? In what position you will have? In
Slight head up
down.
position, sir.
Yeah, head up position. So the field of
25 degree
surgery
head up
is,
positions.
yeah. Why do you keep?
To reduce bleeding at site of surgery, sir.
Yeah, good. So in that head up position, when there is a vein opens up, what will happen?
Air embolisms.
Yeah. So
Yes,
when the patient, that is the diagnosis, when the patient develops hypoxia, tachycardia, hypotension, and loss of EtCO2, the first diagnosis is air embolism.
yes,
Okay.
sir.
So how will you? What is the? How will you diagnose air embolism? It is more of a clinical thing, and if, to diagnose, you will have echocardiogram. Either
Yes,
it is transesophageal echocardiogram or Doppler ultrasound, if it is a
Yes,
non-invasive. So when you diagnose air embolism, what you will do? There is one maneuver to for air embolism, Durant's maneuver.
Hello, sir.
Durant's maneuver.
Yes, sir. Yes, sir. Audible.
Yeah, what is it? Patient in left lateral position and Trendelenburg. Okay,
Yes, sir.
to entrap the air in the right side of the heart,
Right.
so that you
Yes,
can use the central venous catheter to aspirate. So
Yes,
when
sir.
you diagnose air embolism, what is the first thing you will do? Again, 100% of oxygen.
Oxygen.
Then what you will convey to the surgeons?
To stop the procedure.
Yeah, no, not stop. You have to flood the surgical site with saline.
Yes, sir.
Yeah, so that further air embolism is not happening. Okay.
Yes.
So what is the procedure adopted before closure of wound and after thyroidectomy?
Patient in trundle position. Also, a maneuver is given for 10 to 20 seconds, sir.
Okay, why?
To see whether hemostasis is achieved or not.
Yeah, good. Okay. So how do you extubate these patients?
Extubate patient after when the patient is fully awake, sir.
Yeah.
In case of long-standing huge thyroid or
Huge thyroid, yeah.
We can expect tracheomalacia, sir.
So this thing, what you will do?
So that we can insert LMA over intubating tube, sir.
Yeah. Otherwise, you can deflate the cuff of the patient.
Deflate the cuff to leak test, sir.
Yeah. Yeah.
To see whether during positive pressure ventilation, whether any air is leaked
leaking
after
around,
deflating around the cuff, sir.
Cuff, yeah. You can palpate the over trachea and you can see the air leak. Okay.
Yes, sir.
Okay. What are all the post-op complications you can expect in thyroid surgery?
Immediate complications would be laryngeal spasm, tracheomalacia.
Yeah.
Stridor, sir.
Yeah, stridor.
Okay. Immediate delayed would be nerve injuries, recurrent laryngeal palsies, hematoma.
Yeah. Okay.
Hypocalcemia.
Yeah. And delayed will be hypothyroidism. Okay. How do you look for vocal cord movement after extubation?
After extubation, local cord movements can be through flexible laryngoscopy, sir.
Okay.
Or while extubating, LM is inserted and vocal cord movements can be seen through fiber optic FOB through LMS, sir.
Yeah, that's why you do preoperatively, you do indirect laryngoscopy
Indirect
to
laryngoscopy.
record the vocal cord movements. If the patient has preoperative, then you have to record the vocal cord movements. Okay, whether
Yes,
both the vocal cords are moving before thyroid surgeries. Okay, after the surgery, you have to again record in our anesthesia chart whether both the vocal cord are moving or any problem with the vocal cord movement. Okay.
yes,
See,
sir.
what are the nerve injuries common after thyroidectomy?
Superior laryngeal nerve or recurrent laryngeal nerve injury may be common after thyroidectomy, sir.
Okay. Okay. How superior laryngeal nerve, where it will get injured, or recurrent laryngeal nerve, where it will get injured?
Superior
Or
laryngeal
which part of the... Yeah.
superior laryngeal nerve will be injured while doing superior thyroid artery
Yeah,
ligation,
good.
sir.
Yeah,
Inferior
good.
thyroid artery ligation, recurrent laryngeal nerve is commonly injured, sir.
Yeah, good. Okay. So these are the two this thing. So how will you identify or diagnose recurrent laryngeal nerve or superior laryngeal nerve injury?
With superior laryngeal nerve, there will be a change in voice quality will be lost, sir, and voice stamina will be reduced.
Okay.
In unilateral partial recurrent laryngeal injury, there will be hoarseness of voice, sir.
Yeah, good.
Over days, that other vocal cord will be hyper adapted to compensate for this palsy, sir.
Okay.
Bilateral partial recurrent laryngeal nerve injury will lead to bilateral abductor palsy, sir. So that cord will be in adducted position, sir.
Yeah. Okay.
So that patient may go in for stridor, sir. So immediate airway has to be secured.
Okay.
So bilateral complete recurrent laryngeal palsy, patient the vocal cords will go in for cadaveric positions, paramedic positions. So there is more risk of aspirations.
Okay. So how do you do a trial extubation?
Trial extubation is done 48 hours post-operatively, sir.
Yeah.
Trial extubation is done in the Paka OT setup with all instruments and monitors available.
Yeah. Yeah.
After extubation, patient is monitored for 30 to 40 minutes, sir.
Yeah.
Yes, sir.
Yeah. So you have to extubate with full monitoring. Okay.
Yes,
when do you suspect a patient having tracheomalacia?
History-wise, a patient will be having long-standing huge goiter over years, sir.
Yeah.
So that patient may be going for tracheomalacia, sir.
Okay.
During surgeries, that posterior part of thyroid swelling will have impinging of the cartilage over thyroid gland, sir.
Okay.
Then post-operatively, leak test will be performed to see whether tracheomalacia is there.
Okay. So how do you manage tracheomalacia?
Patient is not extubated, sir.
Yeah, extubation is not done when you suspect that.
Not tracheomalacia, sir. So patient is done a trial extubation after 48 hours or 2 to 3 days, sir.
Yeah.
So that fibrous strands will be formed and trachea is pulled, sir.
Yeah. If again stridor is there, you have to consider tracheostomy. Okay. If you are called by the ward nurse that the patient has developed respiratory distress, what you will suspect and how do you manage these patients?
Usually, patient developing respiratory distress post-operative due to hematoma formation, sir.
Yeah, good.
So
how do you manage?
Management will be immediate removal of alternate sutures of the thyroid, sir.
Yeah, good.
And then patient should be intubated as early as possible. As increased hematoma may decrease venous return, causing airway edema, worsening intubation if delayed, sir.
Okay. What are the hyperparathyroidism presentation from the patient post-operatively?
Earliest symptom for hypothyroid presentation would be perioral numbness and tingling sensation, sir.
Yeah, good. Yeah.
Then over perioral and later it will be over hands, sir.
Yeah, fingers. Yeah,
Fingers,
fingertips.
limbs.
Yeah. And immediately after that, laryngeal stridor or laryngeal spasm.
Yes, sir.
Yeah. What is the incidence of hypocalcemia and when an acute hypocalcemia can occur after thyroid surgery?
Hypocalcemia will usually occur after 36 to 72 hours after surgery, sir. Not immediately after surgery.
Yeah.
Incidence.
Incidence is 20% of the patients might develop
Yes,
hypocalcemia. Okay. What's Trousers sign?
Trousers sign when the PP cuff is inflated to over 200 mm Hg, patient will develop extension of fingers and flexion metacarpophalangeal joints and with adduction of thumbs, sir.
Yeah, carpopedal
indicating
spasm.
hypocalcemia, sir.
Yeah, hypocalcemia. What's Chostek sign?
Chostek sign is due to facial nerve.
Yeah, good.
Tapping the course of facial nerve will cause ipsilateral twitch
muscle contraction. Yeah.
Contractions.
Yeah. Does continuation of antithyroid drug or beta blocker is required post-operatively?
Antithyroid drugs not necessary, sir. Beta blocker should be continued at least 7 to 10 days after thyroid surgery, sir. Since half-life of T4 is 7 days.
Yeah.
Beta blocker should be continued, sir.
Okay. What's the short-term preparation of hyperthyroid? Sir was asking emergency thyroidectomy.
Yes, sir.
Yeah. What regional anesthesia can be done for thyroidectomy?
Superior deep cervical plexus block, sir.
Okay.
Then cervical epidural can be done.
Okay. How do you prepare a thyrotoxic patient for emergency surgery? That is what sir was asking. What are the problems associated with administration of anesthesia in uncontrolled hyperthyroidism patients?
Problems associated with uncontrolled hyperthyroidism is hello, sir.
Yeah, tell me.
Patient hyperthyroid patient will have increased vascularity, sir. So more bleeding is expected, sir.
Yeah.
A patient may go in for intraoperative thyroid storm, sir.
Yeah, good.
And arrhythmias may develop intraoperatively if uncontrolled hyperthyroidism patients.
Yeah.
An increased requirement of volatiles, MAC, and anesthetics.
Yeah. So, how do you manage a hyperthyroidism patient in pregnancy?
In pregnancy, propyl thiazole is usually preferred over thiocyanate, sir.
Yeah.
Because it causes comparatively crosses the placenta lesser amount, sir.
Yeah.
Then iodide usually contraindicated in pregnancy.
Yeah. Beta blockers?
Beta blockers used during pregnancy, sir.
Yeah. That's anything else, sir? I think sir is there. Dr. Kalyan, are you there? I think he got disconnected. Okay, there are a few questions there in the chat box. So what is the primary thyrotoxicosis and secondary thyrotoxicosis? That's what we discussed. Yeah.
Yes.
Are you there?
Yes, sir. Yes, sir.
Yeah, sir, come back. Dr. Kalyan, are you there?
Yes.
Yeah.
Yes, sir.
Anything to ask, sir? Anything more to be asked? Yeah. Just now we finished. Anything more to ask?
suppose if this patient is having a retrosternal extension, what are the precautions you will take? What are the problems during induction? Suppose
Yes,
if
sir.
the patient is having a retrosternal extension, what are the problems do you expect during induction? Dilip, can you hear me?
Hello.
Yeah,
Ah,
Dilip.
yes.
Yeah.
Yes, sir.
Go ahead. So
Did
this
you hear
patient
sir's
is
question?
Yes, sir.
Did you hear sir's question?
No, sir. No, sir.
so this patient is having a retrosternal extension.
Okay, sir.
So what are the problems you will anticipate during induction?
Retrosternal extension may go for intrathoracic obstruction, sir, during induction. Patient may develop airway collapse, sir.
Okay.
So awake intubation is still preferred, sir.
Okay. So how will you anesthetize airway for awake intubation?
Usually the nerve supply of nerves to be blocked during for awake intubation usually trigeminal, glossopharyngeal and vagus, sir.
So how will you do that?
For nasal cavity, anterethmoid nerve and sphenopalatine ganglion should be blocked, sir. So 4% lignocaine with adrenaline should be used. Before that, decongestant nasal drops should be given, sir.
Okay.
So nose should be packed with 4% ligno with adrenaline on either side, sir. For 10 minutes, sir. Then for glossopharyngeal block, just below anterior pillar of anterior pillar of tonsil, 1 cm below, 2 ml of lignocaine is injected, sir. Then to anesthetize oropharynx, lignocaine spray is usually used, sir.
Okay.
Then superior laryngeal block and transrectal block cannot be used for this patient because of huge thyroid, sir.
Okay.
So during FOB, spray as you go technique can be used, sir.
Okay.
Or 4% lignocaine, 4% lignocaine nebulization can be given, sir.
Okay.
Yes.
So these are all the methods to block the airway.
Yes,
So
sir.
you should not use muscle relaxants. In case of retrosternal extension, you should be very careful.
Yes, sir.
If you use muscle relaxants, so you will lose control of the airway.
Airway. Yes, sir.
Because if it is an extrathoracic, you can lift the gland. They
Yes,
ask
sir.
by asking your assistants to lift the gland.
Okay, sir. Okay, sir.
It is an intrathoracic retrosternal extension, so we'll lose the airway control.
Yes, sir.
Okay.
Yes, sir.
So maintenance of the patient's spontaneous
Spontaneous
respiration.
respiration. Yes, sir.
Okay.
Okay. Anything else, sir? There are some questions in the chat box. What is the primary thyrotoxicosis and secondary thyrotoxicosis and how they are different?
Yes, sir.
Yeah.
The primary thyrotoxicosis usually symptoms is present with or without the swelling, sir.
Yeah.
Then secondary thyrotoxicosis, patient will have long-standing swelling, sir. Then the patient will develop this hyperthyroid symptoms, sir.
Yeah, yeah.
So primary toxicosis usually CNS manifestations will be predominant, and whereas in secondary thyrotoxicosis, cardiovascular symptoms will be predominant, sir.
Yeah. Okay. What are the common thyrotoxic arrhythmias we come across?
Atrial fibrillation, sir.
Yeah, yeah. Atrial fibrillation is most common. And what is MEN1 and MEN2 syndromes?
Yes, sir. MEN1 includes. Yes,
yeah.
sir.
Yeah, tell me.
Yeah, parathyroid adenoma, Men 1,
Yeah.
pituitary adenoma, parathyroid hyperplasia,
Yeah.
and pancreatic tumors, sir.
Yeah.
2A will include medullary carcinoma, pheochromocytoma,
Parathyroid.
and parathyroid
Hyperplasia.
tumors, sir.
Yeah.
Men
2B.
2B includes medullary carcinoma, pheochromocytoma, and neuromas, sir. Neuromas.
Yeah. So what is Bailey's maneuver?
Bailey's maneuver during extubation, patient will be kept in deep plate, sir.
Yeah.
And that LMA is inserted over ET tube, and
Endocrine tube.
ET tube is withdrawn,
Yeah.
sir.
Yeah.
Then after adequate recovery, patient is extubated.
Yeah. What's caused the diagnostic criteria?
No ideas.
So that is the diagnostic. It is actually a diagnostic tool based on 3 major observations in the patient with thyroid storm.
Yes,
Okay.
sir.
There are that is observations due to diagnose the thyroid storm. Okay.
Yes, sir.
So anything else, sir? Here, temperature, central nervous system effects, gastrointestinal, heart rate, congestive heart failure. So there are so many criteria in that for diagnosis.
Yes,
okay. So anything else, sir?
You covered everything.
Yeah. Hope everything is covered. And if any more doubts are there, just send the questions in the group, Telegram group, and we can discuss. I think almost 1 hour and 40 minutes we have discussed. And I have to thank Dr. Tilip for excellent presentation and discussion. And thank you, Dr. Kalyana Sundaram, for sparing the time, and you have finished your case and just entered directly to the discussion. Thank you.
Thank you, Dilip. Thank you, Jaykumar.
Yeah.
Thank you.
And next Tuesday, we'll be having anesthesia for ischemic heart disease patient, posted for laparoscopic cholecystectomy. So I think this is also one of the important topic for exam. Now, ischemic heart disease for non-cardiac surgery. And we'll try to do maximum out of it. And what I'm preparing is almost we'll be preparing 100 most common questions in each anesthesia case discussion. So that there are a lot of other questions, of course. In thyroid, you will have a hell of a lot of questions. You can have 200 to 250 questions can be prepared for discussion. And what
we have omitted hypothyroidism.
Yeah, hypothyroidism. Yeah, we have omitted hypothyroidism and so on. So most common questions will be based on hyperthyroidism and here, and I think we have covered everything. I think shall we close it, sir?
Yes, yes.
Yeah.
Thank you.
Yeah, thank you everyone, and good night. And for the exam goers, all the best for your exam. And tomorrow will be your DNB practicals, I think. And all the best for the exam going PGs. Do very well, do confidently, and hope everyone will clear. Okay, take your time to answer the questions. Do not panic, and all the examiners are there only to pass you. Okay, good night. Thank you.